Hello there, this is Dr. Mintz. This is a CT head on a patient who is 75 years old, 75-year-old female, and she is having right orbital pain. I'll scroll through this case briefly and you can get an overview of what it looks like, maybe start getting some ideas as to what you think might be going on here. Okay. Well, cutting to the chase, here we have an abnormality. I think you probably saw this. There's an abnormality here. That's good. How will we describe it? You want to be succinct. You want to describe the anatomy involved and the appearance of the abnormality. I would say there is a smoothly marginated mass of relatively uniform attenuation, slightly increased attenuation compared with the brain, and it is in the right parasellar region. Do any of you have an idea what this might be? This is a meningioma. This is an unenhanced study, and the characteristic appearance of a meningioma is smoothly marginated, generally of fairly uniform attenuation, and that is often at or a little higher than the attenuation of brain, and it is broadly based against the sphenoid bone in the right parasellar region. The sphenoid bone is a relatively complicated bone because it extends from one side to another. It kind of looks like a butterfly, and it narrows in this area here. Has a bunch of little holes through it that cranial nerves go through. But anyway, the sphenoid bone is an important bone. You don't need to know all the details of it, but you do need to know it forms this very important anterior portion of the skull base. So this is the sella turcica. That means Turkish saddle, and that's because it's got a kind of scooped out appearance. So if the eyes are here and the back of the head is here, it's kind of like a little cup-shaped thing, and that's where the pituitary gland resides. So this mass is growing in the right parasellar region and is actually extending into the sella turcica a little bit. It's characteristic of meningiomas to be broadly based against the inner table of the calvarium or adjacent to temporal bone or sphenoid bone like this, broadly based against intracranial bone, because they arise from the meninges, the dura, and these are broadly based against dura, and that's where we typically see them, against the convexity of the calvarium like this, and not infrequently in the region of the sphenoid bone. And this is a parasellar location. So this area here would be left parasellar. This is right parasellar. The space in front of the pons is prepontine cistern. So as you know, we have ventricles, cerebral ventricles that contain CSF, but that's not the only place we find CSF. We find CSF in the little nooks and crannies of the brain, including in cortical sulci and large fissures like this, the Sylvian Fissure, and what we call little cisterns. So this is a quadrigeminal body or a quadrigeminal plate, so this is a quadrigeminal cistern. Here we see the vermis of the tentorial, or the vermis of the cerebellum, poking out just a little superior to the tentorial incisura. And I know I'm going through these fast, but I'll touch on these again. So we go down a little bit farther down, and you see that there is a difference between this brain tissue and this, and that's because this is cerebellum in the posterior fossa, and this is cerebral hemisphere in the supratentorial compartment, or in the main body of the intracranial vault. So there's actually a sheet of dura here, and that's also a common place for meningiomas to arise. If you look here, you can see something else. You can see that the cella has its own content. Some of that is invaded by the tumor, but some is not. So some of that's going to be pituitary gland. And if we go up higher, superior to the sella turcica, we are in the suprasellar cistern. This suprasellar cistern is a very important area. It's an important reference point for many processes, and it also happens to be where the circle of Willis is located. And you can see here the tip of the left internal carotid artery and the tip of the right internal carotid artery. That's because in this region of the circle of Willis, the right internal carotid artery and left internal carotid arteries give rise to a right middle cerebral artery and left middle cerebral artery, respectively. And they both also give rise to an anterior cerebral artery. They both also connect to varying extents, connect to the basilar artery. Basilar artery courses along the ventral aspect of the brainstem. And even though we don't see the connections here, it might be just this little thread over here, and often the circle of Willis is incomplete. But this provides collateralization so that if, let's say, one internal carotid artery is occluded in the neck, then the basilar artery and the right internal carotid artery, let's say the left is occluded, the basilar artery and the right internal carotid artery can together contribute blood flow to the left middle cerebral artery by first going to the tip of the left internal carotid artery. So there's collateralization of flow allowed, and this is somewhat unique to this organ to have this kind of anatomic distribution that specifically allows for this collateralization. So again, internal carotid arteries you're going to see in the suprasellar cistern. Kind of has a six-sided appearance depending on how nicely it's portrayed. And you will see the anterior cerebral arteries going in the anterior interhemispheric fissure, which is here. You will see the middle cerebral arteries coursing in what are generally most properly referred to as the middle cerebral artery cisterns, but all you need to know is that they're heading out to the side to go into the Sylvian Fissure. And once they get there, they start branching, and that's where they give off the branches that go to the outer aspect of the cerebral hemispheres. They also have branches that stay in the Sylvian Fissure to supply that area of brain. This is a midbrain. How do I know that? Well, I know that it's brainstem, and because it has this little dot in it, that gives me a hint. That is the Cerebral Aqueduct. That is the channel that connects the third ventricle with the fourth ventricle. I also know because there's this little V-shaped area that's a cistern. That is the Interpeduncular Cistern. That's because this structure and this structure are both cerebral peduncles. They are basically these huge things upon which the cerebral hemispheres rest. And these communicate fiber tracts in the brainstem with the cerebral hemispheres. And obviously that's a very important function. So these do not generally have any processing or neural cell connections, but just big highways of axons going up and down, and that's what comprises these cerebral peduncles, cerebral peduncle on both sides. So that tells me this is midbrain. And midbrain is a little bit more rostral toward the head, a little bit more rostral than the pons. And if we go down, we come to the pons. The pons is right here. And the pons has, as I mentioned, the prepontine cistern, which is just posterior to the cella. So this is the region of the cella. This mass is a meningioma, and it's in the right parasellar region. Here in the left parasellar region, you can actually see the cavernous sinus. Very interesting anatomy, a venous structure formed by the reflections of dura in that area. And there are important nerves that course through there, along with a segment of the internal carotid artery just before it goes up superiorly to branch, which is here. If you follow those down, there they are there. and here you can't really see them too well. There's bone there, but they are in here. So that cavernous internal carotid artery on the left should be fine, but it may be being compromised by this mass. And the other things we have in the cavernous sinus is several cranial nerves, including cranial nerves 3, 4, V1, which is cranial nerve 5, the first division, that's the ophthalmic division that goes to the orbit, and cranial nerve 6. So cranial nerve 3, 4, and 6 basically are involved in eye movement control, which of course is highly precise and important. And cranial nerve 5 is the trigeminal nerve. And the trigeminal nerve has several divisions basically that innervate the face. And so all sensation from the face is conducted back to the brain by 3 branches of the trigeminal nerve. And you can kind of imagine them kind of like this. And so you have the trigeminal nerve, often referred to as V for the Roman numeral 5, V, so it's called V1, V2, and V3. So the 3 divisions of the trigeminal nerve innervate this area, the upper face, mid face, and lower face. And the uppermost is the one that comes through the cavernous sinus. So a mass like this could give you loss of sensation in the forehead, and it can also give you difficulty with eye movement in that specific eye. And this is the basilar artery again, and if we follow this down inferiorly, I think we have a little bit of the trigeminal nerve showing right here. The trigeminal nerve emerges from the lateral aspect of the pons, and this is relatively advanced. I don't expect you to get this first time around, but it's an important landmark because you can see it usually. We can usually see it better than we do here, and it tells us that if we're looking for cranial nerves 6 or higher, it's inferior or caudal to this level. And if we're looking for cranial nerves 1 through 4, they are superior to this or rostral. Superior and rostral depend on what type of anatomy you're talking about and what species it is, but it means specifically toward the head is rostral or cephalad, and caudal is toward the tail. Okay, so here we have pons. What is this? That's the 4th ventricle. This is all cerebellum, and this is pons. Pons means bridge. It's Latin for bridge, and that's because it is bridging a huge number of fibers. Why would they be bridging there? Well, as you know, the cerebral hemispheres represent the body in a contralateral manner, meaning my right side of my body and my right visual field are all represented in my left hemisphere and vice versa. But the reverse is true in the cerebellum, meaning it's all ipsilateral. And since the cerebellum reconciles those inputs from the body going to the hemisphere and provides some coordinating capability, there has to be a way that the right side of the cerebellum can communicate with the left cerebral hemisphere and its fibers. And that's what's happening here. It's a huge fiber track going from one side to the other, and there are some nuclei in there too, including a part of the trigeminal nerve. If we go down lower, we're getting out of the 4th ventricle, and this is the lower part of the cerebellum. Here we still see the pons. What do we have here? Those are the temporal lobes of the brain, and if you go up higher, you see that they merge imperceptibly with the other lobes. The lobes of the brain are a little useful in our description of the general area where things are, but they're really very arbitrary. They have functionally little or no significance, with the possible exception of the central sulcus, which divides by definition the frontal and parietal lobes. And it so happens that sensation and motor control of the body is controlled specifically in those areas, in front of and behind that. Okay, so here we are in the Sylvian Fissure, and the middle cerebral arteries are going to go from the internal carotid artery out that way and branch there. Here we're seeing a little portion of the inferior aspect of the frontal lobe. Here you can actually see the middle cerebral arteries coursing to the right and to the left toward the Sylvian fissure. There's actually a little recess, a little fold there that they are coursing in. They don't actually go right through the substance of brain, and you can kind of glean that property right here. So this is the midbrain. This is a part of the midbrain. We're not quite, we're a little bit higher than where we were looking before. So this is midbrain too, where we have the cerebral aqueduct. Remember, the cerebral aqueduct allows communication between the third ventricle and the fourth ventricle. And you have a quadrigeminal cistern. The quadrigeminal cistern is dorsal to this little bumpy area, the quadrigeminal plate. And if you have a mass here, it can cause an obstruction of the ventricles so that the third and lateral ventricles get dilated, because CSF can't flow to the fourth ventricle. Okay, let's look up a little bit higher. This is the tentorial incisura, and that's because we have a cranial vault like this, and we have the cerebral hemispheres up high, and so the hemispheres are like this, and we have our cerebellum down here in the posterior fossa. But the cerebral hemispheres are separated from the cerebellum in the posterior fossa by a sheet of dura that's angled like this. And thus, if we are in the cerebral hemispheres like this, we won't see any of the cerebellum, but as we go down, we will first see the little part of the cerebellum poking out of that division that is between the cerebral hemispheres above and the cerebellum below. And as we go farther inferiorly, you see a wider and wider swath of that cerebellum. Now, the cerebral hemispheres have cortical sulci. Those are the folds that we see here and there and everywhere. But the more important prominent folds are called sulci. So these are fissures. So this is the Sylvian fissure on both sides. And let's go back down. So this is important to really appreciate where you are, because when you get to an image like this, it's hard to say where you are. Am I in the supratentorial compartment or am I in the posterior fossa? Well, both, because you have brainstem and cerebellum in the posterior fossa, and you have cerebral hemispheres, here being the temporal lobes, in the supratentorial compartment. So there's also a little angulated structure here, and these are the cerebral peduncles that, as I mentioned, allow communication from the cerebral hemispheres to the brainstem and below, and this is the interpeduncular cistern. These things have significance only because they help people communicate about where anatomic abnormalities are, and so people who have a subarachnoid hemorrhage will often accumulate blood here. Why is that? Well, this is where the circle of Willis is, and the great majority of subarachnoid hemorrhages result from aneurysms that are in the circle of Willis vessels. So this is the first place to see subarachnoid blood very often. And then with time, you'll get some in the quadrigeminal cistern and even the superior cerebellar cistern. And then it'll spill out over the convexities of the brain, and it'll start going into the cortical sulci and into the fissures, including the Sylvian fissures here. Now, as far as what folds are which, you don't need to really worry about that. I will give you a discussion of how to tell where the central sulcus is. The central sulcus is the sulcus that divides the frontal lobe from the parietal lobe. And that is an important division, and I'll go through that in another discussion. Here we have the lateral ventricles, and you see how they connect up here. But as you go down inferiorly, you no longer see a connection, but that's because they are arching structures that connect more superiorly. This little calcification is in the choroid plexus of the lateral ventricles, and choroid plexus is involved in the production of cerebrospinal fluid. And here you can see those calcifications more clearly. It's very normal to have calcifications of the choroid plexus. This is calcification of the pineal gland. They are very commonly calcified, and it has no clinical significance as far as we know. Okay, I think that's probably enough for right now. Meningioma, parasellar space, left parasellar space, prepontine cistern, fourth ventricle, superior to which is the midbrain with its little tiny cerebral aqueduct. And we have a quadrigeminal plate, the surface of this midbrain here, and we have a quadrigeminal cistern, the fluid space around it, and we have a suprasellar cistern, which is superior to the cella and is the location of circle of Willis vessels. These are the middle cerebral arteries going off to each side. This little angle is the tentorial incisura, and this is a little bit of cerebellum, specifically the cerebellar vermis, poking its little head out, wanting to be in the supratentorial compartment, so it seems. And this is the third ventricle. So with CSF being formed in the choroid plexus of the lateral ventricles, the flow goes throughout the lateral ventricles and then courses inferomedially from the lateral ventricles, what we call the frontal horns here, toward the third ventricle. So here you can see the lateral ventricles emptying into the third ventricle, and then the third ventricle going down is going to have a little conduit between it and the fourth ventricle, and that's the cerebral aqueduct, that little dot there, and that little dot there, and this little crease right here, and a little bit there, and then you're in the fourth ventricle. Okay, and the other little review point would be that the sphenoid bone is here. There's a lot of complex anatomy in that, and if I gave it to you, you'd forget the most important thing, and that is the sphenoid bone is here. It's kind of butterfly shaped, and the sella turcica is comprised of sphenoid bone, and that's an important thing to know, and the details generally are not. And here are the mastoid air cells, and here's the medulla, and we can still make out the basilar artery there. Okay, that's it for now.